Approximately 6 million people in the United States have heart failure, and about 550,000 new cases are diagnosed each year. The incidence of heart failure increases with age and is most common in folks over 75. It is the most common reason for hospitalization of people over the age of 65 years of age, and about a fourth of those who are discharged from the hospital are readmitted within 30 days. The cost is estimated to be greater than $39 billion annually, and with an aging population, this is expected to increase. Most patients over the age of 66 are on Medicare, so this cost is assumed in large part by the government and your tax dollars. Heart failure is a global term to describe a weakened and distressed heart, but you will hear it applied to an acute blockage of one of the coronary arteries, as happens in an acute MI, or more often as the history of a chronic condition of a diseased right or left heart, referred to as heart failure or congestive heart failure if the lungs are affected. And lastly, you will see it in the hospital as acute exacerbation of chronic heart failure. Predisposing factors that lead to heart failure include heart valve disease due to the stress the incompetent valves have on the left side of the heart, previous acute MIs or silent MIs, which are often experienced by diabetics, congenital heart disease, arrhythmias, especially chronic AFib, smoking or any tobacco use, sleep apnea, infections of the heart, or any condition that results in cardiac muscle damage leading to weakening, remodeling, stretching, and enlargement of the heart muscle can cause heart failure. There are two types of left heart failure, and drug treatments are different for the two types. Heart failure with a reduced ejection fraction, also called systolic failure, is where the left ventricle loses its ability to contract normally. The heart can't pump with enough force to push enough blood into the circulation. Heart failure with preserved ejection fraction is called diastolic failure or diastolic dysfunction. This is where the left ventricle loses its ability to relax normally because the muscle has become stiff. The heart can't properly fill with blood during the resting period between each beat, since the heart is not meant to be a reservoir for blood, but the amount coming in should be exactly the same as the amount going out. When this doesn't happen, or when the monocytes, which are the cardiac muscle cells, are damaged, the heart undergoes remodeling in order to compensate for the underlying problem. Remodeling helps for a short time until hypertrophy occurs and the patient becomes symptomatic with a poorly contracting heart. Remodeling occurs in a number of different ways depending on the initial pathology of the pumping system, but it all results in a multi-pronged effort by the body to improve the situation within the heart and improve systemic perfusion. First, the central nervous system is activated, which causes the heart to beat faster and causes arteries to vasoconstrict, which increases cardiac workload. Because this doesn't fix the underlying problem, the renin-angiotensin-aldosterone system is activated to save urine and increase vasoconstriction. Because the reduced cardiac output or impaired perfusion is not a fluid problem, this action only compounds the situation with fluid overload. The increased fluid volume causes the heart to have to contract faster and more forcefully. If left unchecked, these mechanisms that are meant to compensate for low cardiac output and impaired perfusion lead to increased preload and afterload, which in a weak heart can lead to dyspnea and pulmonary edema and acute decompensated heart failure. The pathologic compensations of remodeling and hypertrophy occur slowly within the heart, but when symptoms appear, it is important that patients take measures to control or limit further damage. Otherwise, the condition will be chronic, progressive, and debilitating with repeated episodes of acute decompensated heart failure. Medications and lifestyle changes can significantly improve the quality of life for these patients, and many hospitalizations can be prevented by appropriate follow-up in outpatient care. On the other hand, frequent acute exacerbations of heart failure episodes severely decrease quality of life and longevity. Heart failure usually goes undetected until the patient presents with symptoms of dyspnea with pulmonary and peripheral edema. Because the cardiac conduction system is affected with the remodeling, dysrhythmias are common. So the first diagnostic test will be a cardiac ECG to assess for dysrhythmias. A common rhythm that can lead to congestive heart failure is atrial fibrillation. Because the atriums are fibrillating and not contracting, the atrias overfill and the ventricles lose about 20% of their normal volume. Without the complete emptying of blood within the atriums, blood clots are more likely to form, which can lead to strokes. Patients feel fatigue and tiredness because of the reduced cardiac output. The body perceives the decreased cardiac output as a need to save urine and vasoconstrict, which compounds the problem with fluid overload. Aspirin, Plavix, Pradaxia, or Coumadin are usually prescribed to prevent blood clots and strokes. Cardiac stress testing may be performed to try to initiate heart dysrhythmias and determine whether coronary artery disease and cardiac ischemia are causing the heart failure. For different reasons, they might do a chemically induced stress test using dobutamine. Laboratory studies usually performed during the initial workup include electrolytes, Bunnin creatinine to assess the kidneys, liver function tests, thyroid stimulating hormone, CBC, and routine UA. The BNP level is a key diagnostic indicator for heart failure. High levels are a sign of high cardiac filling pressures and can aid in both the diagnosis and management of heart disease. The results of these laboratory studies assist in determining the underlying cause and also can be used to establish a baseline to assess effects of treatment. It is essential to confirm a diagnosis of heart failure, to begin to manage the disease, and to rule out renal failure and COPD, which present with similar symptoms. An echocardiogram will be done that can determine the ejection fraction and identify any structural abnormalities in valve or valve malformations. The ejection fraction shows the amount of blood in the left ventricle that is pumped out with each heartbeat. The normal EF is from 55 to 70%, and heart failure with a reduced EF is less than 40%. This would be diagnosed as systolic heart failure. There are a lot more criteria involved in diagnosing what is called diastolic heart failure, which is heart failure with a normal ejection fraction. The diagnostic criteria includes the heart failure symptoms and an increased end-diastolic pressures. A left side heart cath is the most accurate diagnostic to evaluate heart function. The cath usually involves a ventriculography to assess the heart's pumping ability and a coronary angiography to assess patency of the coronary arteries. Although the invasiveness of the cardiac cath increases the patient's risks for bleeding, it allows for thorough assessment and interventions to be done at the same time. Symptoms of left heart failure usually present with dyspnea, which can also occur at night or with lying down, which is paroxysmal nocturnal dyspnea and orthopnea. This is caused by fluid backing up into the lungs. Right heart failure is most often a progression of left heart failure, so signs and symptoms are often mixed. Cough is often an early manifestation of heart failure. We need to assess the patient's activity level and auscultate breath sounds for crackles and wheezing, which usually begins in the bases and spreads upward as the condition worsens. At the most severe state, the patient will have audible crackles and wheezing with frothy, pink-tinged sputum, a sign of life-threatening pulmonary edema. Right heart failure can be a result of COPD or as a consequence and progression of left heart failure. Presenting symptoms are very similar, but also results in damage to organs feeding blood into the heart, such as the liver and lower extremities. Jugular vein distension also signifies a right heart congestion, as the blood draining the head is slow to enter the superior vena cava due to the backup of fluids in the right atrium and right ventricle. Severity of chronic heart failure is classified according to symptoms. The New York Heart Association classification has 4 classes based on physical activity limitations, from no limitations to slight limitations to marked limitations 2. Unable to carry on physical activity without discomfort. Remember that all this has to do with shortness of breath and stress on the heart. The hallmark symptoms of heart failure can be divided into respiratory symptoms of dyspnea, bibasilar crackles, orthopnea, and paroxysmal nocturnal dyspnea. Cardiac symptoms of tachycardia and having a third heart sound. Remember that S3 is the one commonly heard in children and young adults, but in older adults and the elderly with heart disease in S3 often means heart failure, but it can be one of the earlier symptoms of heart failure. The way you can remember that S3 sounds like Kentucky is to remember that Kentucky Derby has the Triple Crown horse race. S4 is always pathological and sounds like Tennessee. The last group of symptoms are perfusion related, such as JVD, peripheral edema, palpable liver, abdominal ascites, and chest pain if the heart failure is caused by an acute MI. This slide shows you the vicious cycle of chronic congestive heart failure and how the syndrome of cardiac damage is self-propelling. Cardiac muscle cells are damaged or stretched, resulting in a depressed ventricular performance. The reduced cardiac output signals to the central nervous system to increase heart rate, increase force of contractions, and vasoconstrict peripheral arteries. Because this doesn't help, the renin-angiotensin-aldosterone system is then activated to save fluids and increase vasoconstriction even more, which results in a sustained hypertension. This slide also shows you where medications are used to interrupt this process. The heart now has 2 additional complications: high preload due to the excess fluids coming in, and high afterload due to the sustained hypertension with the vasoconstriction. Afterload is the resistance the left ventricle must overcome to circulate blood into the systemic circulation. Because of the excess fluid and the narrowed aorta, the heart can be stressed beyond compensatory mechanisms, and the patient will go into an acute decompensated heart failure. Initial medical management of heart failure is to diagnose it by measuring the ejection fraction and managing it with medications. Medications may be IV or PO depending on the severity of the patient's condition. From what we've talked about so far, can you guess why ACE inhibitors and ARBs are the first-line treatment for management? It has to do with interfering with the RAS system to stop conserving fluids and stop vasodilation. As a matter of fact, the Joint Commission requires that physicians document that they have or will evaluate the left ventricle systolic function, which means the ejection fraction. An ACE or ARB must be prescribed if the ejection fraction is less than 40%. Nurses are to verify that the required information is documented by the physician and to provide discharge instruction with patient teaching on activity level, diet, discharge medications, weight monitoring, and management of worsening symptoms. So when treating an acute exacerbation of congestive heart failure, how will you know if medical treatments are effective? What would our patient goals be that are realistic and measurable? First and foremost would be improvement in the number 1 symptom. We want to see reduced dyspnea or shortness of breath on exertion and/or at rest. We want our patients to have breath sounds that are clear to auscultation, and if on oxygen, we want them to be weaned down to room air. We want to see reduced peripheral edema to the ankles, which would indicate to us an improved fluid balance. We can also measure the desired loss of excess fluid volume by seeing a reduction in daily weights and by an effective urine output. Our patients' labs should be within normal limits, but especially the BNP should be less than 100. Total success would be measured by our patients ambulating in the halls on room air without shortness of breath to the nurse's station and back. The initial nursing action should be assessment of the patient's baseline dietary intake through a thorough diet history, also assessing the exercise regimen and smoking. For a plan to succeed, it must be mutually designed by the client and the healthcare providers. Long-term compliance and adherence is the most essential element in reducing morbidity and mortality associated with hypertension and heart failure.